Hello students, today we'll discuss one more very important topic, even though it is a small topic but important topic, that is the anatomy of the ischiorectal fossa. This is Dr. Yusuf signing from Al-Jof University. This is the specific objective which we'll try to cover in this lecture. So first we'll try to identify the ischiorectal fossa, then we'll try to identify the boundaries, and we'll also list the contents of this ischiorectal fossa. So this is how the ischiorectal fossa can be seen when you see from below, and here the skin has been reflected in the perineum, and here you can see the anal canal, and beside the anal canal this is the ischiorectal fossa on either side. Okay, so we'll go into details about this. So it is described as a wedge-shaped space present on each side of the anal canal and below the pelvic diaphragm. Okay, so it is beside the anal canal, and this is the anus here, and beside that will be the ischiorectal fossa, and it is present below the pelvic diaphragm. If you see it in a vertical section at the time, you can see here it is beside the anal canal itself, and it is present below the pelvic diaphragm. Here is the pelvic diaphragm, and it is below the pelvic diaphragm here. So this space is filled with fat. Mainly it contains fat, nothing but the fat, but also along with that there are some important structures we will discuss later, but mainly it is filled with fat and acts as a elastic cushion. This is very important function of this. This acts as a elastic cushion. Why it should act as a elastic cushion? Because it will help in expansion of the rectum as well as the anal canal during defecation. So here is the anal canal. So during defecation it has to expand. So whenever it tries to expand, and then it will push this fatty area, and then it has a cushioning effect within this, and then because of this cushioning effect on either side, this anal canal can expand to a large extent. Okay, so this helps. The main content is fat, and this helps in the elastic cushioning effect, which will help in again in turn the expansion of the rectum as well as the anal canal during defecation. Okay, so the shape is almost wedge shape. This is how it is seen. This is the ischiorectal space, and this is the whole of this is the ischiorectal fossa, this whole thing. So it is almost triangular shape or wedge shape with the base directed downwards and toward the surface and the apex upwards. So the base is almost here near the skin. Okay, and the apex is directed towards the pelvic diaphragm. Okay, so it is almost wedge shape with the apex directed upwards and the base to the external surface near the skin. What is the dimension? It is almost 2 inches in antero-posterior position. So if you measure it anterior-posteriorly, it will be almost 2 inches, and the breadth is, or the width, it will be almost 1 inch, and the below depth will be almost 2 inches. So it is 2 inches in anterior-posterior direction. It is 2 inches from above downwards, which is the depth, as well as almost 1 inch in the breadth or the width. So these are some of the dimensions of the ischiorectal fossa. So it is a small fossa filled with huge quantity of fat, which help in the cushioning effect and helps in the expansion of the rectum as well as mainly the anal canal. So what are the boundaries of this? We'll go much in detail about the boundaries of this fossa. Okay, so the base is formed by the skin, as you can see here. So this is the anus, here is the anal canal, here will be the anus, and beside that will be the skin. So this forms the base for this, filled with fat inside. Okay, so this will be the base of this fossa formed by the skin, and the apex is formed by meeting of the inferior fascia of the pelvic diaphragm, that is also called as the anal fascia, with the obturator fascia. If you can see here, so as I said, this is the pelvic diaphragm, and below this is called as the inferior fascia of the pelvic diaphragm. So this inferior fascia of the pelvic diaphragm and this is called as the obturator fascia. So here is the obturator internus muscle, and deep to that there is a fascia called as the obturator fascia. These two fascias meet with each other. This is the internal fascia of the inferior fascia of the pelvic diaphragm, and this is the obturator fascia. These two fascia meet an angle, and this forms the apex. Apex is formed by the meeting of the inferior fascia of the pelvic diaphragm, also called as the anal fascia, with the obturator fascia. So this is the obturator fascia here, because it is deep to the obturator internus, and this is the inferior fascia of the pelvic diaphragm. This is the pelvic diaphragm, below that will be the fascia. This is called as the inferior fascia of the pelvic diaphragm, and these two fascia meet at an angle and they form the apex of this fossa, ischiorectal fossa. Anteriorly, it is limited by the posterior border of the perineal membrane. So anteriorly it will be limited by the perineal membrane, if you can see here. So this is the anterior posterior position with the lateral view. You are seeing the same fossa from the lateral side. Okay, and here you can see the perineal membrane. So that will be forming the anterior limiting membrane. Okay, so here in this view you cannot see because it is in front of this picture. Okay, posteriorly again there is lower border of the gluteus maximus with the sacrotuberous ligament. If you can see here, this is the sacrum, and here is the sacrotuberous ligament, and here is the gluteus maximus. Okay, that will form the posterior boundary of this fossa. The lateral wall is vertical and formed by the obturator internus. In this way you can see the lateral border. So this is the obturator internus covered with the obturator fascia. So that will be forming the lateral boundary along with the ischial tuberosity, which is below the attachment of this obturator fascia. So it will come deep here and get attached, and below this ischial tuberosity will form the lateral boundary. Okay, so the lateral wall is vertical and formed by the obturator internus with the obturator fascia, and the medial surface of the ischial tuberosity below the attachment of the obturator fascia. So below the attachment of the obturator fascia, it will be directly by the bone, that is the ischial tuberosity, and above it will be obturator internus along with the obturator fascia. And the medial wall slopes upwards and laterally and formed by the external anal sphincter. So here there are sphincters here around the anal canal. This is called as the internal anal sphincter, and here is the external anal sphincter. External anal sphincter is divided into three parts. One is the deep part of the external anal sphincter, then we have the superficial part, and then the subcutaneous part, because they just below this just deep to the skin, so this is called a subcutaneous part, and this is the superficial part, and this is the deep part of the external anal sphincter. So the external sphincter is divided into three. So this is the deep part, the superficial part, and the subcutaneous part, and deep inside we have this is the internal anal sphincter. Okay, so the medial boundary is formed by the external anal sphincter with the fascia covering it below. Okay, so here you can see here there is a fascia which is covering it deep inside. Okay, and the levator ani with the anal fascia in the upper part. If you see above, we have the levator ani which form the pelvic diaphragm. So this will be the levator ani with the fascia of the inferior fascia of the pelvic diaphragm, which will be forming the medial boundary above. Okay. So these are some of the boundaries of this fossa, which is called as the ischiorectal fossa. So we have seen it has a base here, it has an apex here, then the lateral boundary here, and the medial boundary. So these are some of the, and the anterior and posterior also we have seen. So anterior and posterior boundary. So all these are the boundaries of the this ischiorectal fossa. So this is the fossa which you can see when you see from the this view. But apart from that, this fossa extend beyond this space. So these are called as some recesses. These are called as recesses. These are nothing but the narrow extensions of the fossa beyond its boundaries. So beyond the boundaries, it slightly extend deep inside in the anterior and posterior positions. So those are called as recesses. So what are these recesses? The first one is called as the anterior recess. and this passes above the urogenital diaphragm. This is the urogenital diaphragm here. So this is called as the pelvic diaphragm here with the levator ani, and this is called as the urogenital diaphragm. So if you can see here, this is the superficial fascia or the superior fascia of the urogenital diaphragm. So this is just above this superior fascia of the urogenital diaphragm, and the below the pelvic diaphragm here deep inside you can see this is called as the anterior recess. Anterior recess is above the urogenital diaphragm and below the pelvic diaphragm. It has to be below the pelvic diaphragm because whatever is below the pelvic diaphragm, that is called as the Erector Fossa. Okay, so here is the anterior recess. Similarly, we have a posterior recess which is behind. Okay, so this extends deep to the sacrotuberous ligament, as you have seen already. So this is the sacrotuberous ligament, and this is the gluteus maximus. Just above that there is a slight deep extension of this fossa deep inside the sacrotuberous ligament, and this is called as the posterior recess. So this is the anterior recess here, and this is the posterior recess. Apart from these recesses, there is something called as the horseshoe recess. This is nothing but the connection connecting two fossa behind the anal canal. So beside the anal canal, we have seen this is the ischiorectal fossa in the front, and the on the one side, and the ischiorectal fossa will be on the other side also. For simplification, they have shown only one, but there will be two. So these two are connected behind the rectum by one more recess, that is called as the horseshoe recess. Okay, so this is about the recesses which are present here, and this is the remaining part. This is whole thing is the ischiorectal fossa. So apart from this, there are some spaces and canals within the fossa. So we'll go into details about this small space ischiorectal fossa. Within that, again it is divided into multiple spaces. So what are these? The first one is called as the perianal space. Perianal space. So if you can see here, so this region is called as the perianal space. So the perianal fascia extends from the white line of the Hilton. What is the white line of Hilton? So here in the anal canal, where the anal columns end here, so this forms a white line. This is called as the white line of Hilton. So you have already studied in detail about when you studied the rectum. So this is called as the white line of rectum as well as the anal canal. So this is called as the white line of Hilton. So from the lateral boundary of this white line of Hilton, there is a membrane which extends deep into the ischiorectal fossa. This is called as the perianal fascia. Perianal fascia. So the perianal fascia extends from the white line of Hilton medially to the pudendal canal laterally. So it extends from medially from the white line of Hilton all the way up to a canal here, which is again within the ischiorectal fossa. This is called as the pudendal canal. A very important canal which is present in the ischiorectal fossa is called as the pudendal canal. Apart from, I told you that it is filled with fat. Apart from the fat, there are some important contents, like one is the pudendal canal. So this fascia which extends from the white line of Hilton to the pudendal canal, this is called as the perianal fascia, and whatever is superficial to it, okay, which is superficial or below it, that is called as the perianal space. Okay, so the perianal space, perianal fascia extends from the white line of Hilton medially to the pudendal canal laterally, and it separates into subcutaneous perianal space, and deep inside is the ischiorectal space. So deep inside, whatever is there, this is called as the ischiorectal space, and what is superficial to this fascia, this is called as the perianal space. Here the important feature is the fat here is tightly arranged in small locules with complete septa, hence infections are very painful. So this is clinically very important. This region, if there is any infection is present within this perianal space, it will be very painful, because this whole area filled with fat is tightly locked in the form of loculi, okay, with complete septas. So there are complete divisions within this with complete septas. So if there is any infection, there is no space apart from this. So if there is any infection, and if it starts forming pus, and if it starts enlarging, so it doesn't have any space to expand, and then it becomes very painful. So any infections in this region are painful. So it is different from that of the ischiorectal space. Here if there are any infections, they are not painful, because here the fat content is lesser and it is quite spacious. So there are a lot of spaces, so here it can expand, and if there is any infection deep inside in the ischiorectal space, then it is not painful. But if it is in the perineal space, then it will be painful. So that is the difference. So here it is painful, superficial. If it is present in the superficial space, that is called as the perineal space, then it will be painful. If it is in the ischiorectal space, it will be not painful. Okay, so this is how clinically it is important. So this is the ischiorectal space, which is large and deep, and fat here is loosely arranged in loculi with incomplete delicate septa. So that is the difference. Here they are small loculi with complete septas, and they are tightly arranged. Here they are loosely arranged and they are present in loculi, but incomplete delicate septas are there. So it is not completely filled with fat, so a lot of spaces are there, and the fat is also loosely arranged, as well as there are incomplete septas. Okay, so if there is infection in one region, it can spread to the other. If it is filled in one space, then it can transfer to the other spaces, because the septas are incomplete. So easily it can enlarge to a large extent. Hence infections here are least painful. Even if there is pain, it will be least painful, because the swelling can occur without tension. Here it will be tightly arranged, so it will be tension, it will be creating tension, but here without any tension, it can expand to a large extent. Lunate fascia divide the space into suprategmental space, and below this is called as, and the below it will be tegmental space. Again, this ischiorectal space is divided into two parts by a fascia. This is called as the lunate fascia. Okay, so whatever region is above this is called as the suprategmental part, and this below, this will be called as the tegmental. So the ischiorectal space is again divided into two parts by a fascia called as lunate fascia. So there are many fascias here, you should remember. One is the perianal fascia, then this is the lunate fascia, then obturator fascia, then the inferior fascia of the pelvic diaphragm. All these are some of the very important fascias which are there. Okay, so you should be able to differentiate between this. So the lunate fascia is that fascia which divides the ischiorectal space into suprategmental, which is above it, and tegmental, which is below it. Okay, so these are the again the two spaces within the ischiorectal space. Now coming to the third and the most important, that is the pudendal canal, also called as the Alcock's canal. So here is the pudendal canal, the most important, very important content of this ischiorectal fossa. Okay, so this is a fascial tunnel in the lateral wall of the ischiorectal fossa containing pudendal nerve as well as the internal pudendal vessels. Very important structures. One is the pudendal nerve as well as the internal pudendal vessels. If you can see here, so it is a fascial tunnel. It is a tunnel, and this tunnel will help in the passage of these very important structures. One is the pudendal the nerve which is there. So this is the pudendal canal, and this is the pudendal nerve. Okay, so this pudendal nerve divides into dorsal nerve of penis as well as the perineal nerve. So these are two very important nerves which will be supplying the genital region. One will go to the penis and the other will supply the perineal region. Okay, so this is the pudendal nerve which is coming here. Then we have the internal pudendal vessels, the artery and the vein. So they are coming here and they give branches here. These are called as the inferior rectal vessels and nerves. Okay, when nerve is coming from the pudendal nerve, these are the inferior rectal vessels. Then again they further go deep inside, and then they will be giving the artery and vein for the penis as well as even the posterior scrotal nerves and vessels. So it will be supplying the penis, it will be supplying the scrotal region as well as even the perineal region. Okay, so these are some of the important vessels which will be supplying the penis as well as the scrotal region as well as the perineal region. All the structures are within this pudendal canal. So that's why the pudendal canal is very important. So this fascial tunnel which will be present on the lateral wall, near the lateral wall of this ischiorectal fossa. Okay, in the lateral wall of the ischiorectal fossa containing the pudendal nerve. So you already seen the pudendal nerve as well as the internal pudendal vessels. These are the internal pudendal vessels which will further divide. The fascia covering the pudendal canal is fused with 3 fascia. So this is a very important fascia canal which is formed by 3 fascias. Which are those 3 fascias? One is called a lunate, the second is obturator, and the third is the perianal. If you can see here, this is the obturator fascia which is coming down, then it forms the pudendal canal. The other one is the lunate fascia, and the third is the perianal fascia. All these 3 fascia will form this canal. This is called as the pudendal canal, or the 3 fascias which come and adhere to the pudendal canal. Okay, so that's why this pudendal canal becomes much more important. Okay. Now coming to what are the contents within the ischiorectal fossa. We have seen that it is filled with fat. Huge quantity of ischiorectal pad of fat is present within this region. Okay. Apart from that, we have seen that it is also having the pudendal canal containing, which will be giving some important nerves and vessels. Okay, which are those? One is the inferior rectal nerve and vessels. We have already seen there is the inferior rectal vessels which are coming from the internal pudendal vessels, and this is the inferior rectal nerve which is coming from the pudendal nerve itself. Okay, so this, if you see from below, if you reflect the skin, then you can see beside the anal canal or the external anal sphincter, beside that is the ischiorectal fossa, and these are the vessels which are, as well as the nerves which are coming. One is the inferior rectal nerves and vessels which are coming from the lateral side, just beside the ischio. This is the ischial tuberosity. So here is the pudendal canal, and these are the direct nerves which are, as well as the vessels which are coming. Inferior rectal nerves as well as the vessels. Then we have the posterior scrotal. Or in case of female it will be labial nerves and vessels which will be coming. So here you can see here, so these are the posterior scrotal, the nerves and vessels which are coming. Okay, so if you can see here, see this is the posterior scrotal as well as the vessels which are coming from the this again the pudendal canal. Okay, so here is the posterior scrotal which is going in the front, even though the ischiorectal fossa is behind. So this posterior scrotal vessels and nerves will go to the scrotum in the front in case of male, and in case of female it will be called as the labial vessels and nerves. Then apart from that, we can also see the perineal branch of the fourth sacral nerve. So here you can see here, this is the perineal branch of the fourth nerve. So if you can see here, this is the perineal nerve which is coming again from the pudendal nerve, from the fourth sacral nerve. Apart from that, there are perforating cutaneous branches of S2 and S3. If you can see here, apart from that, there are also perforating cutaneous nerves and nerves which are coming from here. Okay, so there will be a lot of cutaneous nerves which will be coming again from the same region. Apart from that, the pudendal canal with its content also is a content of the ischiorectal fossa. So all these are the structures which are coming from the pudendal canal. So the main structure will be the ischiorectal pad of fat along with the pudendal canal and its contents, and the structures which are coming from this pudendal pudendal canal contents, that is the pudendal nerve itself as well as the internal pudendal vessels. So those are the inferior rectal nerves and vessels, posterior scrotal or the labial in case of the female nerves and vessels, then the perineal branches, perforating branches, these are the branches which are coming from the pudendal canal and its contents. Okay, so these are some of the important contents of the ischiorectal fossa. To be very broad, mainly the fat content here and the pudendal canal and its contents. Okay, so this is how it can be seen. So here is the anal canal and the rectum above. So this is the internal anal sphincter, and here they have shown you the external sphincter along with the 3 parts, the deep, the superficial as well as the subcutaneous part of the external sphincter. And here below we have already studied the pudendal canal and its contents. Now coming finally to the applied aspects, how it is clinically important. One is the ischiorectal abscesses. This is a very important clinical presentation when you go to the clinics. So this is a very common thing which can be seen. One is the ischiorectal abscess. If there is any ischiorectal abscess within the ischiorectal fossa, as I said, if it is in the ischiorectal space, then it will be not be painful, and if it is in the perineal space, then it will be painful. Okay, so this is how we can differentiate between the where exactly it is present. So this is a very important feature which will be presented clinically with the ischiorectal abscesses. Then these ischiorectal abscesses will be start draining. So they can be draining deep into the rectum or the anal canal itself, or superficially directly. So these are called as the fistula in ano. Fistula in ano, if you can see here. So this is called as the fistulous tract, which is draining the abscess deep inside in the ischiorectal fossa. So these are called as the fistula in ano. Okay. So the pus in the perineal space leads to severe pain. As I said before, if the pus is within, if the infection is within the perianal space, then it will be very painful. But if it is in the ischiorectal space, then it will be not be painful. And the second important feature of this abscess is if it is unilateral, it can become bilateral. It can go, the infection can go to the opposite side. How it can go? Through the horse-shaped recess. We already seen the horseshoe-shaped recess will help in the transfer of the horseshoe-shaped abscess will be transferred from one side to the other side. Abscess from one fossa spread to the opposite side behind the anal canal. So behind the anal canal, the two ischiorectal spaces are connected with each other with the horseshoe recess, and that will help in the spread of infection from the one side to the other side of the rectum and the anal canal. So that's why this is very important. Okay, so usually these infections, if you don't treat it in the time, it can become bilateral and they start draining into the anal canal itself or outside directly in the form of fistula in ano. Okay, so these are some of the important clinical aspects of this ischiorectal fossa. Apart from that, there is something called the hiatus of the Chauvet. Hiatus of the Chauvet. This is the failure of the origin of the levator ani, which is the present here, from the obturator fascia, leads to herniation of the pelvic viscera into the corresponding ischiorectal fossa. So if there is failure in the origin of the obturator levator ani from the obturator fascia, then the pelvic contents, which are deep inside here, so they will have a space through which they will be start herniating into the ischiorectal fossa, to that corresponding ischiorecta. It can be unilateral, so it can be or bilateral. Usually it will be unilateral. This is because of the failure of the origin of the levator ani muscle here, which will be failed to origin from the obturator fascia. Here this is the obturator fascia, so it doesn't take origin from the obturator fascia, this levator ani. Then it leads to a space here from where the pelvic contents start invaginating into the or herniating into the ischiorectal fossa. So this is called as the hiatus of the Chauvet. Okay, so these are some of the applied aspects related to the ischiorectal fossa. So this is all about the ischiorectal fossa. We have studied the boundaries, as well as we have identified the ischiorectal fossa. We have studied its boundaries and its dimension, shape. Then we have studied the contents of this, as well as the division within the ischiorectal fossa and its clinical applications. Okay, so if you have any further doubts, you can definitely write to me and I will try to answer. So these are my references. Thank you. So if you like this video, you can press the like button, and if you want to subscribe and get regular updates, as well as if you want to listen and want to learn more about anatomy, you can definitely subscribe to my channel and you will be getting regular updates also. Okay, thank you very much.